for coming. It is really such a privilege to be able to introduce Dr. Magdalena Cerdá. First, I'll give you the formal background and then some informal background as well. Dr. Cerdá is a professor and the director of the Center for Opioid Epidemiology and Policy at the Department of Population Health at NYU Grossman School of Medicine. She obtained her doctorate from the Harvard University School of Public Health. She's a former Robert Wood Johnson Health and Society Scholar and a former faculty member in our department before eventually getting to NYU. Her research focuses primarily on two great challenges in improving population health and health equity: substance use and violence. Specifically, her work addresses the social and policy determinants of drug-related harms, the causes, consequences, and prevention of violence. In her most recent work, she's applied methods from epidemiology, statistics, econometrics, and pure science to answer questions about the role that the COVID-19 pandemic has had on the lives of people who use drugs, the impact that policies and interventions at state, local, city, and national level have on overdose and violence. She is a staggeringly productive researcher. She's published more than 300 peer-reviewed publications. She serves as the senior editor of the International Journal of Drug Policy and is a member of the National Academy of Medicine Action Collaborative on Countering the U.S. Opioid Epidemic. I've known Magda for, I think it's about 15 years, since the early days when she was a faculty member at Columbia. She and I have collaborated on countless grants, projects. I just looked it up on PubMed. We're co-author on 95 of those 300 publications. And I just want to say what a warm and generous colleague Magda has been to me for many, many years. She's not only extraordinarily brilliant, but also very pragmatic. She can kind of get to the root of the issue right away. Like so many meetings, Magda would say, so what you're saying is, and just can summarize some complicated point in a very eloquent way. But I just want to underscore the generosity of spirit, of collaboration, of mentorship. It's been a great 15 years, hoping for another 15 plus coming down the pipe. So thank you, Magda, and I'm looking forward to it.
Thank you. Thank you, and it's really great to be here and to see so many familiar faces. Actually, a lot of the work that I'm going to talk about involves a lot of you. A lot of it involves Carrie, as you will see, but also many of you, including Kara, Sylvia, Emily. So really, it's Debbie. It's really great to be here. So I've tried to distill together two kind of disparate areas of work, which are on overdose and gun violence, and really tried to think through how we can use epidemiology to inform an effective response to these two issues. Okay, all right. So really what motivates me is figuring out what to do about the substantial decline in life expectancy that we've seen in the United States. In fact, we are right now, the life expectancy in the US is one of the lowest it has been in 20 years. And in fact, we've experienced the largest decline in life expectancy now since World War II. So this is really, I think, a crisis, a public health crisis. And so I focus on two of the main drivers of the decline in life expectancy, which are overdose and gun violence. As you can see from this chart here, unintentional injuries involving, among others, overdoses, as well as homicides and suicides involving primarily firearms, are among the top 4 leading causes of death across all age groups. So if we think about what can we do about the decline in life expectancy, in particular by honing in on these two major drivers of the decline in life expectancy, which are overdose and gun violence, for me as an epidemiologist, really what I care about is figuring out how I can use epidemiology to inform effective solutions. And so I ask myself, what are some of the questions that we as epidemiologists can help answer to address these critical issues? And so, of course, there are many questions one can ask and answer, but in the talk today, I thought I'd focus on 3 of those questions. First, I think we can help answer and provide insights on the impact that state and local laws have on access to evidence-based interventions to prevent these problems, and the impact that they have on risk of injury and death. Second, I think they can help inform about how and where we should target evidence-based interventions. And then finally, it can help inform what types of interventions work best for each setting and population. So today, I'm really going to talk about trying to answer those three questions, bringing in some of my work on overdose and gun violence. First, I'll talk about the work that we're doing at my center at NYU, the Center for Opioid Epidemiology and Policy, to identify solutions to the overdose crisis. I'll talk a little bit about the profile of the problem and then highlight salient examples of our work, much of which involves a lot of you guys doing policy evaluation, forecasting overdoses in the future, and simulating optimal intervention packages. Then I'll shift gears and talk about the second area of my work, which is around identifying solutions to firearm violence in urban areas. Again, talking a little bit about the profile of the problem and some salient examples of our work, really focused here on simulating optimal intervention packages. And then talk a little bit about what I'm planning for the future. Okay, so first area, really a lot of my work right now is focused on identifying solutions to the overdose crisis. Why do I care about this? Why is this an important topic to talk about? Well, unfortunately, the United States is the global leader on overdose deaths. And the problem is only increasing with more people dying of overdose every year. We've gone through 4 waves of the crisis so far. It started out in the late 1990s with the proliferation of the use of commonly prescribed opioids to treat chronic non-cancer pain. And that really led to an increase in overdoses involving commonly prescribed opioids. That's the green line that you see here. However, as government, state and local and federal government enacted measures to regulate opioid prescribing, the prescription opiate supply became tighter to access, and that coincided with a drop in price of heroin. We saw a surge in overdoses involving heroin. That was the second wave. Then with the introduction of illegally manufactured synthetic products like fentanyl into the illegal drug market, we saw the rise of the third wave in the blue, which was really driven by fentanyl. And right now we're in the fourth wave, which is still in the red, which is still primarily driven by fentanyl, but increasingly in combination with stimulants like opioids and methamphetamines. So while we've seen a stark rise in overdoses across the country, the problem really does vary by locality. So this is a figure showing you the trends in overdose by type of opioid product over time by state. And so that what you can see is that actually there's a lot of heterogeneity in the extent to which states have been affected by this problem. For example, you can hone in on West Virginia, which has really seen all of the waves of the epidemic in a terrible way. But then there are other states like Nebraska that have been largely unaffected. So this, to me, the heterogeneity in the experience of this crisis really highlights the importance of taking a localized approach to addressing this problem. Okay, so then if we think about how can we address this problem, what can we do? So I think the interventions really fall into 4 buckets. A lot of the work, particularly since the beginning of the epidemic, has been on regulating opioid prescribing to prevent inappropriate use of prescription opioids and diversion of prescription opioids into the illegal drug supply. Now, increasingly in this 4th wave, which is really driven by a very lethal illegal drug supply, a lot of the work focuses more on harm reduction, so reducing the harms associated with drug use and preventing deaths. There's also a lot of work on improving access to evidence-based treatment for opioid use disorder, and increasingly, although very nascent, tackling social drivers of drug use-related harms. So again, if we go back to those 3 questions that I posed at the beginning, that I think as epidemiologists we can answer about important public health problems. Today, I'm going to be talking about how we are trying to address these, answer these 3 questions as they apply to the problem of overdose. Talking about first, work that we're doing evaluating the impact of state and local policies on overdose risk, forecasting where and how to target interventions to prevent overdose, and estimating optimal intervention packages for different populations and settings. So first of all, let me start with some of the work that we're doing in policy evaluation. We've done a lot of work. We're doing a lot of work with the grants that I have ongoing that you see listed here. But just in the interest of time, I'm going to give you just a couple of examples. A lot of this work has been done in collaboration with people here. So first, I thought I'd highlight some of the work that Dr. Martens and Dr. Hassan and Dr. Rudolph have all been involved in, really thinking about the evaluation of prescription opioid policies and their impact on opioid prescribing and overdose deaths. And so here I'm highlighting a grant that Dr. Martens and I have looking at this question. So one of the when I think about the impact of prescription opioid policies on overdose deaths, I'm really interested in looking at both intended and unintended consequences of these policies. If you look at this graph, you can see the trends in opioid prescriptions in the blue bars. And so you can see that as opioid prescriptions increase, overdoses involving commonly prescribed opioids in the red line also increased. And as policy measures were enacted to regulate opioid prescribing and opioid prescriptions declined, you also saw that overdoses involving commonly prescribed opioids in the red line stabilized and declined. However, you also see that as the prescription opioid supply declined, overdoses involving synthetic opioids in the blue and heroin in the green increased. And so that to me raises questions about whether these policies that regulate opioid prescribing had any kind of unintended consequences. And so what do I mean by that? The question here is whether as the prescription opioid supply became harder to access because of all of these policy measures, did the cohort of people who had initiated opioid use with prescription opioids, were they forced to shift to the illegal market and start using heroin and other illegally manufactured synthetics that were easier to access and cheaper? And so in that way, did the policies that restricted the prescription opioid supply have the unintended effect of contributing to the rise in overdoses involving heroin and synthetics? So we've looked at the question of intended and unintended consequences across a range of different prescription opioid laws. However, again, in the interest of time, today I thought I'd highlight one of the studies that we've worked on answering this question of unintended consequences. And this work really focuses on one of the leading state-level responses to the overdose crisis, which is the enactment of what are called prescription drug monitoring programs with mandated queries. What are those, or otherwise known as PDMPs? These are comprehensive databases that prescribers and pharmacists must check before prescribing a controlled substance like an opioid or before dispensing it. PDMPs with mandated query mean that the pharmacist and the healthcare practitioner are actually legally required to check the database before they prescribe or they dispense a controlled substance like an opioid. So some work, including by us in the earlier stage of the overdose crisis, really in the first wave that, remember, I told you was driven by prescription opioids. Some of that work has really shown that more comprehensive, rigorous PDMPs were associated with a decline in overdoses involving prescription opioids. However, the question that we had here is, what's happening with the impact of these prescription opioid policies at the current stage of the overdose crisis, where we're not talking a problem that's driven by prescription opioids, but we're really talking about a problem that's driven by the opioids in the illegal market? Are we still seeing that overall benefit in terms of overdose reduction, or are we seeing some of these unintended consequences that we hypothesized? So the first thing we did is we looked at the impact that state enactment of PDMP must-query laws had on opioid prescribing. And here we focus on two indicators of what we consider potentially high-risk opioid prescribing. That is high-dose opioid prescriptions, defined as 90 or more MMEs, and long-duration prescriptions, which are 30 or more days. And so what you can see here is that state enactment of PDMP must-query laws are indeed associated with a decline in both high-dose and long-duration opioid prescribing. So you look at this and you think, great, this is a success. The PDMPs, they're still doing what they're intended to do. They're reducing potentially high-risk and appropriate opioid prescribing. Okay, But then what happens with overdose? What happens? Are we still seeing the decline in overdose associated with the enactment of PDMPs that we saw in the first wave of the overdose crisis? Unfortunately not, we're not seeing that. So here the story is a little bit different. So here what I'm showing you is the relationship between state enactment of PDMP must query laws and county level opioid overdose deaths by type of opioid product. And what you can see is that enactment of these laws is associated with an overall increase in overdose deaths and including an increase in opioid overdose deaths. We are still seeing the decline in overdoses involving prescription opioids, but prescription opioids are just not so much a significant driver of overdose deaths at the current time. And that's why we're seeing the overall increase. And really that overall increase is driven by an increase in overdoses involving heroin and synthetics, which really reflects fentanyl. So what this suggests is that measures like PDMPs are still effective in terms of regulating opioid prescribing, but at the current wave of the epidemic, where we're dealing with an illegal drug supply that's really driving overdoses, measures like PDMPs are not going to be an effective way to address the overdose crisis. Okay, so I think right now with what we're dealing with is a problem of a highly lethal drug product, particularly fentanyl, that's leading to a lot of unnecessary deaths. So I think a lot of the work and a lot of the focus really needs to be on harm reduction. And so what is harm reduction? Harm reduction is a series of policies and services that try to meet people where they are and treat people who use drugs in their communities with dignity and provide them with the health services and the social services that they need to lead fulfilled lives. And importantly, to reduce unnecessary injury and death from overdose. So we've done a lot of work on harm reduction. One of the first areas of work in harm reduction that we looked at was really the impact of leading harm reduction policies at the state level. One of the leading state responses to harm reduction has been the enactment of what are called overdose Good Samaritan laws. What are these laws? Essentially what they are is laws that are made to encourage bystanders that witness an overdose to call for help. And how do they do that? They do that by reducing the potential costs, the potential penalties associated with drug possession, right? So that might be like not being charged for drug possession, not being arrested for drug possession, if you're a bystander who calls for help. So we looked at the impact that Good Samaritan laws had on overdose deaths. We looked at them in conjunction with naloxone access laws because they often tend to co-occur, so it's really difficult to separate the two. And what we found is that the impact of Good Samaritan laws on overdose deaths really depends on how expansive and how much protection these laws offer. So here we're looking at the relationship of Good Samaritan laws with opioid overdose deaths and then with heroin and synthetic overdose deaths. And so as you can see in the orange lines, Good Samaritan laws that just protect a bystander from being charged, but don't protect them from being arrested, have really no impact on overdose. But Good Samaritan laws that protect the bystander from being arrested are associated with a decline in opioid overdose deaths, and notably a decline in overdoses involving heroin and synthetics. So really that suggests that the most expansive Good Samaritan laws that provide the broadest protections to bystanders can be an effective policy tool to encourage people to call for help and to reduce overdoses. So while, of course, Good Samaritan laws are important and, providing incentives to call for help is an important part of the harm reduction response, harm reduction response goes way beyond that, right? And so I think a critical part of the overdose prevention toolbox is making harm reduction services more broadly available. And so when I talk about harm reduction services, what do I mean? I mean, for example, syringe distribution programs, fentanyl, drug checking equipment, dissemination of drug checking equipment, so that people can check the drugs that they're using and make a conscious choice about the practices that they're going to pursue based on what the content of the drugs is. I mean, overdose prevention centers like the centers we have in New York City, where people can actually consume illegal substances under supervision without fear of arrest and getting the support that they need. And I mean community-based programs to distribute naloxone, which is a medication to reverse overdoses. So there's a lot of evidence suggesting that these types of interventions are really effective. They're effective at preventing increase in skin wounds and infectious disease in overdose. However, unfortunately, they're often not available to the people who need them. And a lot of counties, a lot of places in the United States are not getting these evidence-based services. For example, we looked at the distribution of community-based naloxone distribution sites. Again, naloxone, one of the most important things you can do is make available naloxone to reverse overdoses. And what we found is that, in fact, only 15% of counties have community-based naloxone distribution programs. So we have this huge problem. We have an overdose crisis where more people are dying every day. It's driven by illegal drug supply. Harm reduction services are more than ever important, and yet they're not getting to the people that need them. So that has really led us to a new study that I'm just starting, which really tries to move beyond looking at state laws and drilling down to the local level. And why is that? Because I think that actually harm reduction service availability and access to a lot of these harm reduction services that I just talked about is actually strongly shaped by local laws, by laws in counties and in municipalities. Those laws that actually regulate the operation of, for example, syringe distribution programs, the possession and distribution of drug paraphernalia, and what's deemed a local nuisance. So Dr. DiMaggio and I just started a study where we're trying to ask what municipal laws amplify and restrain the access and availability of harm reduction services, and also how do they shape overdose and other drug-related harms in municipalities. We're looking at 3 different types of laws: those that regulate the possession and distribution of drug paraphernalia like syringes and naloxone, those that regulate the operation of syringe service programs, and those that have the ability to declare rental properties a nuisance. The last one is because nuisance law is actually one of the things that are deemed a nuisance is calling for help. And so you can imagine that if there's a law in place that penalizes rental properties, if too many people call for help, that's not going to be really helpful in incentivizing people to call for help in case of an overdose. In this study, we are collecting data on these laws in 486 municipalities across the 50 states. So a big challenge. So far what I've told you, the research that I've done so far, really focused on 50 states, right? And, there are a lot of challenges with doing state level evaluation, but at least a lot of the data on the state laws is actually publicly available. So that's great. However, the big challenge, and more challenge than we thought when we started, of doing this work of drilling down to the local level is that suddenly you're not dealing with 50 states where you already have data collected. You're dealing with almost 500 municipalities where there's actually no data collected. There's actually no data on municipal laws, on municipal harm reduction laws across the country. So in this study, we're collecting these data on harm reduction laws at the municipal level for the first time. And let me tell you, that's pretty challenging. And so we're doing this because it's so challenging. We're actually doing this in 2 ways. So what we proposed in the proposal and what we're doing, the main approach is manual extraction and coding by 3 people. So far, it's taken us a year to complete extraction and coding of 2 of the 3 laws. We are doing inter-rater reliability, and sometimes that's a real challenge because even with very highly trained RAs, you still find cases where one RA will identify a provision in the legal code and another one will miss it. And then also what we found is that, as you do more data collection, you start to realize that there are questions you should have asked at the beginning that you didn't ask. But then it's really hard to change those questions because that would be going back to the beginning, which was a year ago, right? So there are a lot of challenges associated. And needless to say, this is 1 year of data. We're going to have to go back and redo this in another year, right? And ideally, what you want is annual data, right? So to see what the impact changes in these laws has on overdose. So that has led us to what I would call a high risk, potentially high reward new project that we're undertaking, which is really figuring out how can we reliably and feasibly update laws over time by using AI, a large language model to do automated coding. So what we're doing is we're using a technique called retrieval augmented generation. And what we're currently just developing the prototype to do this. And we start with a collection of municipal codes and research queries. So imagine these are the cities, like the city of Chicago, and these are the questions that we're asking of the legal codes. Then we use an embedding model to index these source documents and retrieve what might be potentially relevant sections. Actually, we're able to do this in a better way than we could do just with a keyword search with humans. Oh. Okay, great. Because we can actually, because these embedding models are actually able to semantically identify pieces of code that humans would not have been able to identify with keywords. And so imagine that these are the excerpts that were extracted. And then we use a large language model to evaluate these segments, to filter them and to figure out whether they're relevant or not. So imagine, we'd identify certain segments as relevant or not relevant, and then we're able to answer the relevant question. And then also the model is able to actually provide us with supportive citations so that we can actually validate it. So what we're doing with this is we're going to have the fully humanly coded data for all of the municipalities, for all of the laws. And then what we're going to do is we're going to replicate it with this large language model approach and figure out to what extent does the large language model replicate what we're able to obtain with humans, with the hope that in the future, we won't have to rely on human manual coding, but actually we'll be able to update laws through this automated process. Also, the hope is that we, as part of this project, we're developing this publicly available dashboard for these laws to encourage other people to do research in this. So as part of that, we're also going to make all of these tools publicly available so that they're useful not only for our work, but for other researchers who are doing work collecting data on any kind of municipal laws. Okay, so that a lot of that work really focused on policy evaluation. As I mentioned to you before, I think a second area where we can really play a role is helping municipalities figure out how overdoses are going to evolve in the future so that we can forecast where and how to target interventions. And so that leads me to a study that I'm currently co-leading with Dr. Brandon Marshall at Brown University. So local jurisdictions must often make choices about where to allocate resources in order to have maximal impact in terms of overdose reduction. However, they often make decisions about where to allocate resources based on what's actually outdated data, right? Because overdose data is often years behind. And the problem with that, with using that outdated data, is that actually the overdose crisis is really changing in a very quick manner. And so the past overdose data may not really reflect the future risk for overdose. It may not really reflect the areas that you actually need to target to prevent overdoses in the future. However, I think we can leverage new methods, particularly using machine learning, to proactively identify future community level risk and inform service delivery. So that led us to the study where we're actually trying to test whether overdose prediction tools can reduce overdose rates, in this case by 40% in 5 years in Rhode Island. This is a randomized controlled trial where towns are randomized to either receive these predictions about what neighborhoods are going to experience an increase in overdose in the future, or to not receive that information. Then we apply ensemble learning models to predict which 20% of neighborhoods across the state will experience 40% of overdose deaths. Why 20% of neighborhoods? That was actually decided by the Rhode Island Department of Health, because what they said is, look, we have limited resources. We really need to focus our resources and the resources of our community organizations in those places that are going to experience the greatest burden. And so we need you to figure out what are the 20% of neighborhoods that are going to experience 40% of deaths. So that's what we are trying to do with our model. And then we're trying to work with community-based harm reduction organizations across the state to steer their services to those areas that we forecast are going to experience an overdose in the future. The first piece of this is really applying these machine learning models to test whether actually these models can identify the 20% of neighborhoods with 40% of overdose deaths. We used a range of different data sets, including surveillance and census data. We used a range of different spatial predictive models, and then we made predictions. The model was actually able to perform very well. The test data was able to obtain a 40% prediction of overdose deaths, and the validation data 44%. So we were able to successfully create this machine learning model that was able to accurately predict overdoses in the next 6 months in Rhode Island. Okay, but that's just a model, right? Really, what you care about is whether the model is actually going to have any impact on people and on services. So that takes us to the second piece of this project, which is how do we make the information about these overdose predictions actually available to people? And so how we've done that is our colleagues at Brown have created this dashboard through Prevent Overdose RI, which creates a map of all of the towns and the neighborhoods within the towns in Rhode Island. Here I'm just honing in on Providence. And for those towns that were randomized to receive the predictions, the map will show in shades those neighborhoods that are going to experience a rise in overdoses in the next 6 months. And then these maps are also going to provide practitioners with information about what these neighborhoods are like. Then we also do a data academy with local community organizations across the state to teach them what do these dashboards mean, what do these predictions mean, how can you use them. So now what we're doing is really evaluating through the trial the extent to which these predictions and this community engaged process actually leads to a change in the spatial allocation of resources and leads to a reduction in overdoses. So stay tuned for results on that. Okay, so far I've talked about policy evaluation and overdose prediction. I think the third piece that is a really important contribution that we can have is estimating optimal intervention packages for different settings and populations. This work is work that I'm doing with Dr. Keys. And I actually think this is really important right now because we're at a time where a lot of jurisdictions across the country are receiving a lot of money through opioid litigation settlements, and they need to figure out how to use that money. And so we as epidemiologists can help them figure out how to use that money by using simulation models to help them figure out what would be the optimal investment to achieve their stated objectives. So Dr. Keys and I have started to do that as part of what's called the NIDA Healing Community Study. This is one of the cornerstones of the NIH response to the overdose crisis. And this study, we're focusing on the New York State site. This is a study led by Dr. Nabila El-Bassel at Columbia University School of Social Work. And what the study aims to do is to reduce overdose deaths by 40% using a randomized trial. And so what we were tasked with by the study PIs in the New York State site is to help jurisdictions figure out where to allocate resources in order to get to that 40% reduction in overdose deaths. And so we use simulation models, in particular agent-based models, to help New York counties decide how much to increase uptake of 2 evidence-based interventions in order to reduce overdose deaths. Those are increased delivery initiation into medication to treat opioid use disorder. You'll see there are 2 medications, buprenorphine and naltrexone, that have been shown to be effective at preventing overdose. And the second is making naloxone more available. We did think that the amount of investment needed really probably differed by pre-existing characteristics of different settings. And in particular, we hypothesized that the level of investment needed probably depended on what was going on the ground before that, so particularly depended on pre-existing treatment availability and urbanicity. I'm not going to go into all the details, but just showing you 2 salient and I think representative examples of what I mean by the need for a localized response. So this graph here shows you the increase in naloxone and medication to treat opioid use disorder needed to reduce overdose deaths in an urban community that had high pre-existing levels of treatment availability. In such a setting, you would need to increase treatment initiation by 150% and naloxone distribution by 200% to reach this 40% reduction in overdoses. However, the story is very different in this other county, which is rural with low pre-existing treatment service availability. In such a county, you need to increase treatment by 300% and naloxone distribution by 1,000% in order to reach the same target. So really showing you that the level, it's not, you need to think about the actual setting and the infrastructure in each setting when you're advising jurisdictions about the investments that they need to achieve their objectives. So to close out all of this work on overdoses, overdoses are really increasing across the country with rising rates that involve both opioids and stimulants combined. In the current stage of the crisis, approaches that regulate high-risk opiate prescribing do still decrease high-risk opiate prescribing, but they also have unintended consequences. I think harm reduction services are really critical, but they're limited. And I think there's a real opportunity to think through both state and local laws as important levers to make these services more available. And finally, I hope I've illustrated how we can use epidemiologic methods to evaluate what works, forecast where and how to target interventions, and advise jurisdictions about optimal intervention packages. Okay, so that was a run through through a lot of the work that we're doing on overdose. So now let me pivot to the second area of work, which is firearm violence. If you remember from the beginning, really the draw here is to tackle two of the leading causes of the decline in life expectancy. You'd think this is a hard pivot and completely unrelated, but actually not. What I hope you will see is that we can answer some of the same questions as we're answering with overdose. We can also answer with firearm violence. Actually, I think overdose and firearm violence are related. They have common causes. They're directly related to each other, and we can also think of common approaches to address them. So, why firearm violence? Fire violence is another key public health problem, unfortunately, for the United States. More Americans died of gun-related injuries in 2021 than in any prior year on record. As with overdose, the problem only got worse after the start of the COVID-19 pandemic. Obviously, one of the big drivers of this problem, why we have this problem in this country and other high-income countries do not, is because of firearm ownership. We have the highest prevalence of firearm ownership in the world. So again, as an epidemiologist, I really want to use epidemiology to make things better, to figure out what works to make things better. In the past, I've done a lot of work evaluating the impact of state and local policies on firearm violence. But right now, at the current time, my work is really focused on this third of the three questions, which is really trying to figure out, using simulation-based approaches, what types of interventions might work best for different settings and populations. Again, this is work that Dr. Keys and I are co-leading. Okay, so again, really focusing on estimating optimal intervention packages for different settings and populations. So there are a lot of different interventions one can consider when one thinks about how to reduce firearm violence. This list here is actually not an exhaustive list, but it's just 3 different examples of the types of approaches we have considered in our work. And so the types of examples I'd like to share with you today. So the first couple of examples that I will show you really focus around firearm regulations, because firearm regulations might be an important policy lever because they can shape access and use of firearms. And if we're talking about firearm violence, and one of the big drivers is firearm ownership in this country, really, targeting firearm regulations may be an important lever. So here, our work has really tried to contrast the value and the population level effects of 2 kinds of approaches. One is a high-risk approach that really tries to limit access to firearms among those people who are at highest risk for violence, with a population-based approach that increases the costs of firearm use across the whole population. And then I'll tell you a little bit about a new initiative that we're doing, trying to figure out the potential effect of broader violence prevention interventions that address social and economic drivers of violence. So again, we've done a lot of work on the simulating potential approaches to prevent gun violence. All of this work has really focused on using agent-based model as a method to understand the propagation of violence and ways to address it. The work that I'm going to be sharing with you today really is focused in New York City, where we're using an agent-based model to represent 15% of the adult New York City population. We built a model that represents the community districts and that places agents supposed to represent adults, New York City adults, into the New York City community districts. And so we start with asking a question about what's the potential impact of a high-risk approach. So one of the leading suggestions, one of the leading types of policies proposed to address gun violence is really around purchase prohibitions, that is prohibiting the ability to...
Health and safety reasons. Take care of this, please.
The ability to purchase a firearm for those people. You're not going to prohibit everybody from using a firearm, but maybe if you prohibit those people who are at highest risk for violence, then you might be able to bring down rates of firearm violence. And so here we've looked at different ways to define what kinds of groups might be at highest risk for firearm violence and what impact prohibiting them from purchasing firearms might have. In the interest of time, I'm just going to highlight one of the potential risk factors for firearm violence, which is alcohol and drug use. So we know that alcohol and drug use are two of the strongest predictors of firearm violence. We've seen a strong relationship between alcohol and drug use and violent crime. For example, or most relevant to our study, California found that people with DUI convictions before they purchased a firearm had nearly 3 times higher risk of committing a violent crime. So our question was really motivated by this research showing the strong link between alcohol, drug use, and firearm violence, and we wanted to figure out what could happen to firearm homicide in New York City if we prohibited people who had a DUI history from purchasing firearms. And so first we looked at answering the question just among those people who had this DUI arrest or a DUI conviction. So what would happen to them specifically if we prohibited them from purchasing firearms? And so these are results from our simulation model. And so in the blue bar here, imagine this is the rate of gun-related homicide among all agents with a DUI misdemeanor conviction. And then we're comparing that to the same agents, but if we prohibited them from purchasing a firearm. And so that would lead to an 8 to 9% decrease in firearm violence. Then if we went broader and we looked at anybody who had a DUI ever, that's the solid line here. What would happen if we prohibited all of those people from purchasing a firearm? And that would lead to a 23 to 27% decrease in firearm homicide among this group. So among the group, right, among the high-risk group, pretty good. A substantial potential decrease in gun-related homicide with these purchase prohibitions. Okay, but as epidemiologists, we're also concerned not only with the high-risk group, but we're concerned about the whole population. And we're concerned about policies that will actually have a population-level effect in decreasing gun-related homicides. And so what happens there? Well, unfortunately, the story's not so rosy then. So this is the same kind of simulation where we're simulating these different kinds of purchase prohibitions, but now we're looking at the gun-related homicide rates across the whole population, instead of just among the high-risk group. And so if you look at population level rates of gun-related homicide, the purple is under no intervention. And then these two are, imagine that you prohibited those with a DUI misdemeanor conviction from purchasing a firearm for 5 and 10 years. And then the greens are, imagine if you prohibited those with a DUI arrest from purchasing a firearm for 5 or 10 years. So really small decline, right? So at the population level, not much of a decline. So while it actually does have high value for affected groups, it actually does not transpire to a substantial population level effect. Okay, so then that takes us to, well, what can have a population level effect? And so that, for us, really led us to ask about contrasting high-risk approaches with population-based approaches. Like with this work, like with a lot of our work, really inspired by the work of Jeffrey Rose and the thoughts of Jeffrey Rose about high risk versus population-based approaches. And so that led us to this second study, which really asked us to figure out basically how broadly would we have to expand our affected group in order to actually get a population-based impact, right? A population-based reduction in firearm homicide. And so that led us to contrast a number of different scenarios. First of all, still keeping with this high-risk approach, how far would we have to expand the definition of the high-risk group in order to get to this population level effect? So we contrasted 3 different scenarios. Imagine that we prohibited purchases from the smallest group, those with a history of involuntary psychiatric treatment or a DUI conviction, a medium-sized group, those with a restraining order or a drug misdemeanor conviction, and the largest groups, those with any kind of misdemeanor conviction or felony. And then what happened if we contrasted these high-risk approaches with a population-based approach that raised the price of firearms across the whole population through an excise tax? So we've looked at this in many different ways, but just to give you one salient example, here are the results where we were trying to test what kinds of interventions would actually lead to a 10% decline in gun-related homicide. And here again, in the blue is the base rate without any kind of intervention. And so what we found is if you just prohibited purchases from the low prevalence group, even if you were able to prohibit it among everybody in that group, which is impossible, you'd only get to a 2% decline in gun-related homicides. In contrast, in order to get to a 10% decline in homicides, you'd need to ensure that at least half of the medium prevalence high-risk group actually was prohibited from purchasing firearms, or at least a quarter of the high prevalence high-risk group was effectively prohibited. Or in contrast, you'd have to increase the price of firearms through taxes by 35%. However, what I find actually most interesting of all of this is the red bar at the end. And what this shows is that it's really not an either or scenario. It's not just a population-based approach or a high-risk approach. It's both together. And in fact, what we found is that if one enacted purchase prohibitions among high-risk groups and raised the price of firearms, so the population-based approach, you'd be able to obtain double the impact that any kind of intervention in isolation could achieve. Okay, so that really highlighted a lot of the work that we do around firearm regulations. But if we think about violence prevention goes beyond just firearm regulations, right? And a lot of it also is based on evidence-based approaches to prevent violence by addressing social and economic drivers of violence. And so this is work that Dr. Keys and I are really just starting out, looking at what potential population level effects could be of programs that prior randomized trials have been shown to be effective at preventing violence through providing supportive social services like increasing employment, providing clinical counseling and mentorship. This is part of the Violence and Inequality Project, which is led by Dr. Sharkey at Princeton. And what he really wanted to do with this project is to provide a public resource to make data on gun violence available to multiple different audiences, including the broader public. And this is basically what a consortium, a multi-methods consortium that tries to tackle urban gun violence, using all of these different methods, and also at the same time engaging stakeholders in the use of data to figure out what works at the local level. Part of this work is actually making data on gun violence and shootings available. And so there's a website associated with this project that provides such data. So Dr. Keys and I are co-leading the agent-based modeling piece of this work. But what we're trying to do is to build a fully flexible agent-based model of shootings that would actually reflect the basic dynamics of shootings across cities. We're working to develop this basic model, which we would then refine through a multidisciplinary network. And the ultimate hope with this is really to offer a platform to test the effect of multiple interventions to disrupt surges of violence in cities across the US. Just to give you an idea of what this model looks like, agents are grouped into group tiles, which reflect gangs. They're also nested in neighborhoods. They're connected to each other through a social network. And violence is really, the probability of shootings is driven by gang tensions, social tensions across the social network, and tensions across the neighborhood. And so what we're doing is using these agent-based models to identify and estimate the population level effect of these three interventions. These are interventions that have been shown in RCTs to be effective at reducing violence, but we want to go beyond those RCTs that really just tell you about the local effect among those people that are treated. And we want to figure out what could be the effect of these interventions in the social network, in the neighborhood, and to then be able to ask through these models, how far would we have to expand these interventions in order to get to a population level effect of these interventions across the city. So stay tuned for findings on that work. So again, now that I've talked to you a little bit about the work that we're doing, thinking through optimal intervention packages around gun violence, let me put it again all together. So I think firearm prohibitions that target multiple high-risk groups do have the potential to reduce firearm homicide, particularly among the affected groups. But really, the effectiveness of those high-risk prohibitions depends on the size of the group, the strength of the relationship between the risk factor and violence, and the extent to which the risk group is actually effectively disarmed. We also really found that modest population-based approaches like increasing gun prices actually can have the same impact as high-risk approaches, but actually that the real solution is coupling these high-risk approaches with population-based approaches. And finally, I think hopefully I've illustrated how simulation models can help us identify the optimal interventions to reduce gun violence in different settings. So I've shown a lot of different information, asking 3 different questions across 2 important public health problems. Let me put it all together. People in the United States are dying at younger ages than their counterparts in other high-income countries. Drug overdose and firearm violence are 2 of the leading contributors to that problem. And I think we can use epidemiology to figure out what works to address these intersecting issues, to evaluate the impact of existing policies and interventions, to forecast emerging trends, to help jurisdictions figure out where to target their interventions, and to also advise jurisdictions about what they may expect in terms of outcomes with different investment allocations. In some of the future work, I really want to put this work on gun violence and overdose together and think about pursuing novel research on the intersection between overdose and gun violence so that we can actually figure out common approaches to address the 2 together rather than in isolation. I also want to build on this work, tracking emerging trends and forecasting overdose, but also expanding to gun violence. And finally, a lot of my work really is focused on fostering innovation around evidence-based approaches to increase the reach and effectiveness of interventions to prevent overdose and gun violence. This will involve some of this work that I mentioned, developing large language models to automate the extraction of policies, tackling a lot of the methodological challenges we are all working on when we're trying to identify the causal effect of these policies and programs. And finally, as we're working with Dr. Keys, thinking about building a modeling consortium, bringing together experts using different methods to really think about optimal approaches to help jurisdictions figure out what works to address these problems in their communities. Thank you so much, and thank you to my collaborators and funders.
Thanks, Max. I wanted to get your thoughts on, it seems to me, kind of reading the news, and there seems to be a big backlash against harm reduction. So for a few years, we saw this real expansion of support for these types of approaches, and I think especially what's been going on in Oregon and just the rising rates of overdose overall, you see this kind of, this isn't working, right? We tried your harm reduction approach, and it's a big failure because overdoses are still going up. What's your response to that? Like, how do you keep people on board with this approach?
Yeah,
and the sentiment in the air.
Yeah, no, that is something that we've been struggling with a lot. So we actually evaluated the impact of Oregon M110 on overdoses because of that same sentiment. And what we found actually is that, so Oregon M110 basically decriminalized the low-level possession and use of all drugs. And there was all this fear about it leading to a dystopian future. And we looked at the data and we showed that actually there was no impact of Oregon M110 on overdoses. So overdoses in Oregon did not increase because of that measure. But the problem is, I mean, the real challenge is that a lot of these measures are enacted at the same time that other factors are happening. And there are two factors that I think are really important. One is just the spread of fentanyl, right? We are talking about a very lethal drug supply, and a lot of these places that have enacted these more liberal harm reduction laws are also starting to, right now, at the same time, be affected by fentanyl, and also be affected by COVID, and also be affected by a housing crisis. And so there are a lot of confounders that I think are why, you know, people are seeing these increases in overdose, which are real, and they're blaming it on these laws because that's what they see. But so because of that, I think that really it's more urgent than ever to use rigorous epidemiologic methods to really get at what's the right answer to the question about what are the impact of these laws and these services. Yes, Debbie. Thank you.
So, you know, the care and thought that goes into the epidemiology, the accuracy of the answer to get out of it, it's really important. But I was taught by this little piece there about following through which is something you actually start to see that yet. They particularly being advised. Do they do anything with the advice? And there are so many forces at this point of self-interest and money and politics and everything. I was just wondering, how do you implement on these little findings?
Yeah, absolutely. Yes, we are doing. Oh, sure. So the question was really about how the challenges with epidemiologic methods. Of course, we take great care at trying to use rigorous methods to answer causal questions, but then there's the challenge of actually advising jurisdictions and to what extent does that actually happen, of working with local stakeholders, and to what extent do they actually adopt the recommendations that you're giving. Does that summarize it? Okay. So yes, absolutely. I think that's actually a really exciting new piece of my work. So we started to do it with Provident. That was the forecasting work that I showed with Rhode Island. And so how we do it is, for example, in that case, my colleague, Brandon Marshall, he has a long-standing relationship with the Rhode Island Department of Health and with community-based organizations across the state. And so we worked with them to develop our grant proposal. And so every step of the way with the study, we meet with them every month. We report to them on what we're finding. They're part of who defines the questions. And then, you know, like with a big piece of that work was not only, you know, developing the predictions, but was making sure that people actually were using them. So a lot of our work has gone into the dashboard and to the data academy and tracking whether organizations are actually using it. And it seems like some of them are and some of them are not, and it's really challenging. With the local harm reduction laws work, that's also a big piece of our work. So part of what we're funded to do is, again, to develop this dashboard of cities, which will be part of City Health Dashboard, so that we can share information on the local harm reduction laws so that other people can use the data. And so we've already started a pilot phase where we're working with 5 city governments across the country to develop the dashboard for them first, to figure out, you know, doesn't work for them, what would a good dashboard look for them before we build it out. We're also doing work evaluating overdose prevention centers in New York City. That's work we're doing with the Department of Health in New York City. So basically, I think the answer is work with them from the beginning to develop the questions that you're asking and involving them in every step of the way, and invest a lot in dissemination afterwards. Thank you. Yes, John.
Yeah, I've got a question. Someone who knows nothing about the topic what happened before the curve that you showed for the overdose waves? Like, what was the entry point into the water? What was the increased availability of prescription medication before that? The overdose rate was similar to other countries, or yeah, what happened before?
Yeah, so before we had a phase where we had a problem with opioids, but that was mainly driven by heroin. We then had a problem with stimulants, which was really mainly driven by cocaine and crack. But this particular wave, it does seem to be worse than anywhere else, and it really did seem to stem from this medical approach, and really, I don't want to blame doctors. I mean, a lot of it was really, and we've shown the pharmaceutical industry and the marketing by the pharmaceutical industry of prescription opioids as safe, non-addictive ways to treat cancer, chronic pain, non-cancer pain. And so you can see how that really proliferated in terms of prescribing practices, and then the increase of the use of prescription opioids, both medically and non-medically. Yeah. Yeah. Yeah, oh, great, what great question. Yes, that is something that I really want to pursue. We're not currently funded to pursue it, but we're trying to get at it right now in a very limited way by using drug arrest data, and we're collecting data in all of the municipalities on service infrastructure, so harm reduction services, both funded by the health department and by community organizations, so that we can get at some level of information on enforcement and service availability. It's not great. So one of the new proposals that we're going to be writing, we're going to be submitting for June, is led by Sprupa Joshi at Michigan to measure actual enforcement of these laws. Kara.
I was super excited to hear about very cool that that's being done. And I wondered, like, as you guys get more into it, given all your expertise in ADD and has actually been able, like, having that project where you're actually like doing a trial of this, has it like gone back and I don't know, have you guys like gone back and like been, oh, actually, we want to iterate on these models and do X, Y, and Z, or like actually this is like, I don't know.
No, but that's a great idea. No, I love that idea though. We have not done that, but we are actually, Carrie led the submission of a grant proposal we just submitted to build this opioid modeling consortium, so that we would bring together people like Brandon and us. So bringing together machine learning, agent-based models, systems dynamics models, to work with local jurisdictions, counties across the country, to figure out what might work for them to use their opioid settlement money. So we're trying to marry the two in new work. But I really love your idea of leveraging an RCT. We haven't thought of that yet, but we may get on that. We may get on that. We may talk to you about that. Charlie.
Initial videos were just staggering. We've all seen it. That's just unbelievable. Point in U.S. history. I'm talking to DC legislators. We came together over this exact question about life expectancy and the top two things for deaths of despair challenges. Of course, we're supposed to talk about this. But number two on that list are firearms, particularly around suicides. Now, the legislators that were there, the only reason Republican legislators came was because the conversation was about overdose, which is involving the rural districts, small town USA. They would not open and engage in conversations about the U.S. gun violence. And I'm wondering if you have any thoughts about how perhaps the gun violence prevention interventionists and so forth can learn from what I think is progress in the overdose prevention community, at least in terms of getting recognition.
Yeah.
Of it as a problem and something needs to be done about.
Yeah, no, absolutely. That's a really interesting question. Especially because you think with overdose, it's such a stigmatized issue, right? There's such a like a moral connotation to that, which makes it difficult to bring jurisdictions on board. But actually, we have seen that even like with legalizing drug checking equipment. Actually, Republican governments are in support of that. I think it's because of this idea, this narrative about it's not just the other, it's everybody around us, it's our friends, our neighbors, our family members who are dying of overdose. And like the police, the EMS, they're seeing it every day, and they're seeing it in their families, and so you can't get away from it. And so I think that that's part of the narrative that has helped bring in buy-in to overdose. Now, I think you also can't get away from gun violence, although perhaps it performs in a different way. So I wonder if part of it is thinking about the narrative that we're using in overdose and how we can apply it to gun violence. But also, I think the other thing there, and why I'm interested in looking at the intersection of the two, is that I do wonder, because they have common causes, whether we can think about integrated approaches and interventions that could address both, rather than, we have our violence intervention and we have our overdose intervention and we're like spending a ton of money on many different things. Can we also think about comprehensive approaches in communities, like thinking about some of your work, Charlie, for example, with greening and with built environment? Can we think about interventions that could actually address both together? And that could also bring in, the buy-in from the gun violence people with the people who are working on overdose. Yeah. Oh, yeah.
But they are simply unwilling to talk about ultimately firearms, and that is that we have almost 2 gun restriction. So, they're not willing to talk about the firearms and the supply, which is the one thing that seems to be heavily forward.
Yeah.
The gun law.
Yeah.
Anyway, so thank you. I really appreciate that.
Thanks. All right.
And so unless there are any other questions,